Hello guys and girls, so today we are going to discuss about one of the most important topics of community medicine, and that is the concept of trials. Believe me, this is one of the most logical and analytical topics of community medicine. But why are we so much afraid of this topic? The reason is we run after definitions, we run after flowcharts, we run after formulae. But today we are not going to go about definitions and formulas and all those big flowchart. Today we are going to go with something which I always call it as ground level approach. We are not going to go with definitions. You are the clinician, not me. I'm going to ask you questions, you are going to teach me, and we are going to go with this ground level approach. That's why I dare you. You can't get a single question wrong after listening to this video of this topic. Okay, so without further ado, let us begin with the concept of trials. So before I begin with my word, let me clear you exact what this case control will be. We are going to begin with case control versus cohort, right? So let me begin by explaining you the crux, what actually the case control and cohort trials are. Okay, so let us begin with case control. In case control trial, the basic crux line is the disease has already occurred, right? The disease has already occurred. If you are studying any risk factor association with the disease, using the principles of case control trial, the basic idea is the disease has already occurred and you are going retrograde, right? You are going retrograde. The disease has already occurred and you will be going retrograde in time. Forget about these terms. We are going to go with ground level approach. You are the clinician, right? You are told to assess the association of smoking with lung cancer. What will you do? Using the principles of case control trial, what will you do? We are in 2021. What will you do? You will select 100 lung cancer patients. You will select the subjects who are already having the disease. You are going to call 100 lung cancer patients and 100 controls who are not having lung cancer patient, right? For comparison, you will be calling them in 2021, right? Right now in OPD, you will be giving them forms. This is the idea, practical approach, right? You will be giving them forms and you are going to ask them to fill up details which will be going in this direction. This is the main idea of case control. The direction is important. You are going retrograde. So what will you do? You will be asking them questions, right? How many, you are studying the risk factor of smoking versus smoking to the lung cancer. So what will you ask them? In 2020, how many packs of cigarette did they smoke? In 2019, how many packs of cigarette? In 2018? In this direction. Additionally, you can ask some other things as well, right? Family history and all those things. And this is the direction. So 100 lung cancer patients are in your OPD. At that time, you are giving them forms and you are asking them to fill up details in this direction, right? The number of cigarette did they smoke in 2019, 2018, 2017, 2016, other association like family history, all those things. If they have undergone any OPD procedures, if they undergone any radiological assessment, anything, right? This would be the direction. And then those 100 lung cancer patients, those 100 cases would be compared with 100 control, right? 100 cases. That is the idea of case control, right? So without further ado, let us begin with the idea of cohort trials. What happens in cohort trials? Temporality is the crux. Disease has not yet occurred, right? Disease has not yet occurred. You are going to start with exposure. And the direction is in any type of case, in any type of cohort trial, the direction is always and always, it is anterograde, right? Be it prospective, be it retrospective, be it embispective, the direction is anterograde. Forget about these terms. Right? Let us talk like clinicians, right? You want to study the importance of asbestos exposure with lung cancer, right? Using the principles of cohort trial. What will you do? You answer me. Okay? What will you do? You will select 100 subjects. You will select 100 people. Who will you select? You will be selecting 100 people who are having asbestos exposure, right? You will select 100 industry workers who have asbestos exposure, right? Asbestos, factory and all those things. So you will start beginning the follow-up of those 100 subjects who are getting exposed to the asbestos in industries, right? So yeah, you select an industry which has asbestos exposure. You call those 100 patients, you call those 100 subjects, not patients. You call those 100 subjects for serial follow-up. Let's suppose for 10 years. This is costly study. You call them for 10 years. Every year you call them. Every 6 monthly you call them. You go for serial CT scan. You go for serial chest x-rays. You go for all the radiological investigations. You go for physical examination. You go for, or you follow up the patient for their clinical complaints. And you are following them up entrograde. This is the most important direction. You are following the entrograde, and that is the reason why I said that temporality is the word that forms the crux of cohort trials, right? So that is what the example I gave you. As a clinician, you want to study, you will be calling those 100 subjects who are working in industry, having the exposure of asbestos every 6 months. Every 6 months you are going to follow them up. Every 6 months you are going to follow them up. So funding would be required. We'll study that further, all those factors. This is the basic idea. Now let us discuss quickly about the 3 types of cohort, right? The 3 types of cohort: prospective, retrospective and ambidextrous. Prospective is, we discussed, we are in 2021. You are going to follow up till 2031. That is prospective, current to future. Now, what is retrospective? Now, these people always confuse retrospective cohort with case control. Both are totally different. And you have to remember it anyhow. In any type of cohort, the direction is always retrograde. Okay, so what happens in retrograde? We'll talk as a clinician. You want to do a retrograde cohort study of asbestos exposure. What will you do? You are in 2021, right? You have those 100 patients. Disease. You have those 100 subjects. What will you do? You will ask the industry owner. Give me all the records. Of those 100 patients from 2011 to 21. From 11 to 21. Give me all the records. How many hours did they work? Right? If you have any radiological, if you have undergone any periodic physical examination or health checkup, give me all those records. How many hours did they work? How many hours did they have any sickness in between? Give me all the records. And you are in 2021, but you are going to start the study from 2011, right? You are going to start the study from 2011. And the most important, mark my words, you are going in this direction, right? This is prospective. This is retrospective. From 2011 to 2021, you have the records. Forget about the current time. You are in 21. But what will you do? You will switch back. You will time travel to 2011. You will obtain all the records. You have all the records. You start the study from 2011. Then you see the records of 11, 12. Then you see the records of 13, 14, 15, 16. And you are going in retrograde direction. Am I making sense? Sure. This is the core concept. You might, in any MCQs, they will confuse you with retrospective cohort with case control. In case control, what do? You have 100 lung cancer patients in your OPD. You are asking them to fill in the details. Retrograde, right? Retrograde. And what will you do in this? You have all the records and you are going to start the study. The same way do you do in prospective. But in this, you have the records. The classical finding is, the classical word over here is, you are going to study with records. Now, what is ambidextrous cohort? Very simple. It is a mixture of both this. What do you do in ambidextrous cohort? In ambidextrous cohort, you obtain all the records, right? You study till 2021, right? With the help of records. Same as we did in retrospective. And then from 2021 to 2031, you are going to continue the study. Till you get the disease. Right? Till you get the disease. That is ambidextrous, right? So let us talk about the specific terms, exposure and disease, right? What happens in ambidextrous? The exposure has already started. You are in 21. The exposure has already started. And disease would be occurring over here, right? In prospective, exposure is not there, disease is not there at the start of study. Exposure and disease will start after the beginning of study, right? That is the basic difference. So don't confuse between retrospective cohort and retrograde case control. The direction is important. Whenever in MCQs, they'll confuse you with this. You have to be very clear. This is the basic idea. And we will figure out all those specific flow charts and terms at the end. But let us first of all behave as clinicians. We'll figure out the ground level approach, right? Okay, guys and girls, so fasten your seatbelt because we are going to go with one of the most important concepts, with one of the most important parts of this concept of trials. All of them are sure shot question in any entrance exam around the globe, right? Any entrance exam. But the prerequisite of this segment, you need this thing anyhow. You don't need a pen, paper, anything. You don't need any specific knowledge. All you need is a brain, right? And a little bit of common sense, and we all are clinicians, right? You are going to answer all those questions, not me. You are going to answer all those questions. Let us begin with in which condition, in which trial out of case control or cohort you will get this problem. You are going to answer, not me, right? Just imagine in which condition, in which trial would you get the loss of funding, or you need more time or money, right? Would you get in case control? What do you do in case control? Let us take our example which I give. Right, you are going 100 patients, giving them 100 photocopy, 100 rupees, finished. You don't need any funding, right? So, would you get loss of funding, or more time is required, or more money is required, big, crores of rupees are required? No, you won't get in case control. You would get loss of funding problem, or more funding is required in cohort, because in the study we took, right, you are studying from 2021 to 2031, serial CT scans, serial physical examination, serial checks, X-ray for 10 long years, crores of rupees. You are going to give the money to physicians, radiologists, you are going to call them, transportation, everything, 10 long years, crores of rupees. So you might get the loss of funding. You start the study in 2021, right? In 2025, the director goes back, the agency which told you that you have to you have to do this study. The director of that agency goes bankrupt, he dies. What do? You don't have any money. In 2025, you get the loss of funding. So the loss of funding issue, would you get in case control? No, a clear blatant no. Would you get, you get the loss of funding in cohort. C is for cohort, CC is for case control. I'm going to write over this by your answer, right? So you get the loss of funding in cohort, 10 long years, whooping amount, crores of rupees, right? So you get loss of funding, the director dies, director said I don't have money, okay, you have to stop the study, right? So this problem you get in cohort, right? Now, attrition problem. What is attrition problem? Attrition problem clearly indicates what actually this problem is loss of follow-up. Imagine, where would you get loss of follow-up? For 10 long years, you are teaching those 100 patients that beta, you are getting exposed to asbestos, you are smoking. So when you will get lung cancer, my study will be successful. Keep on getting exposed to asbestos, keep on smoking. At least just logically imagine, out of those 100, at least 30 people will say that okay, I'm smoking. These guys are expecting me to get lung cancer, I should stop smoking, right? So attrition problem, that is loss of follow-up. Out of 100, 30 people will think that I don't want to work in this asbestos factory, I might be getting lung cancer, I will stop smoking, I might be getting lung cancer. So the loss of follow-up, the attrition problem, loss of follow-up or attrition problem, you will get in cohort, sure shot, basic understanding, common sense, brain, right? You won't get that attrition problem in case control. They are already suffering from lung cancer. You are giving them forms, fill up the forms, finish. There is no loss of follow-up, right? Now, okay, which study will you go for in rare disease? If you want to study a rare disease, right? Rare disease. You just answer which, you are the clinician, you have to study a rare disease. Which will you do? You will go for cohort, you will go for case control. Let's suppose we go for cohort. I feel that, okay, I want to go with cohort to study a rare disease. 10 long years, crores of rupees, right? That agency is paying you. You are following up study, and at the end of 10 years, you say, sir, disease to nahi hui, paisa barbad. Okay? So, you won't go for cohort. What the director will do? Will get the hell out of you, right? So for a rare disease, let us be definite. Go for case control. The disease has already occurred. We are going retrograde. In cohort. The disease, you study for 10 long years. Still you might not get disease. Loss of crores of rupees, and the director will get hell out of you, right? So what will you do in rare disease? If you want to study, you go for sure shot, you go for case control, right? Now, what will you do if you want to study a common disease, right? If you want to study a common disease, you just imagine you are the clinician, you want to study a common disease, hypertension, diabetes, dyslipidemia, all those things, they are commonly occurring, right? They are commonly occurring. You don't have to put special effort. Let's suppose, you select, 100 doctors in a study, you select 100 doctors in a study, stressful branch, at least, 30, 40, I don't know what the exact stats, at least some of them would definitely be getting hypertension. Hypertension is a common problem, common disease. It's a common disease, huh? Definitely you will be getting some patients and you can compare them, right? You can study, atherosclerosis is very common in dyslipidemia, right? So, the two examples I give. In dyslipidemia patient, right, in a hypertensive clinic, you follow up those 100 dyslipidemic patients for years altogether. Every time they come for follow-up, you keep a record for 10 long years. How many are getting atherosclerosis? How many are getting ischemic attack? How many are getting acute coronary syndrome, right? All those common disease. So for common disease, you will be going for cohort. That is legible, sensible thing to do, right? Now, ethical problem. In which study would you get ethical problem? You only answer. Obviously in cohort, very logical. Obviously in case control, the disease already occurred. They are in your OPD, 100 lung cancer patient, there is no issue. In cohort, you are exposing them. Go better, go smoke. That is why you will smoke and after 5 to 10 years, I will get my study successful. So, you get an ethical problem in cohort. You are exposing people. You are exposing people to a exposure to a risk factor which you expect that might develop the disease. So, ethical problem, short cohort. Right? You don't need to cram all those things. Just imagine, in within seconds you can answer which disease. First of all, you have to go for the ground level approach, right? When would you get recall bias? You only answer in the recall bias, you will be getting in case control. Why? You are giving the forms. Some might remember, some might say, okay, those who are already developed lung cancer, they might say, no, I smoked. Some control who are not getting lung cancer, they might not remember. There is recall bias. It is exactly upon the subjects, how much they recall, right? In cohort, you are not asking them, you are exposing them. You know how much of exposure they have, how many hours of working in the industry, how many packs of cigarette did they smoke. It is not based on the patient, it is based on you. So, recall bias you will get in case control in forms. In forms, they are going to take wrong, right? They don't remember you are doing in 2021, 10 years back, how many cigarettes did they smoke. They randomly think, right? So, recall bias, sure, you get in case control. Now, in which type of trial you can ask for multiple risk factors. Let us take the example of our college and all. You can, in case control, you are giving them forms, you can ask for multiple exposure. How did lung cancer patient, you can ask how much did they smoke, does they have any family history, any other exposure, any other tobacco abuse, any other industrial exposure. You can ask for multiple exposure, whole form is there. Medical students know. In this analysis, we give so many questions, right? So, multiple risk factors. Where you can do that? You can go for case control, right? Now, in which trial you can go for analysis of a number of disease, right? Number of outcomes. This is multiple risk factor or multiple exposures, right? Go for case control, right? In number of outcomes, number of diseases, you can go for cohort. Why? I'll explain you. For 10 long years you are following up. Some might be developing lung cancer, some might be developing some other lung fibrosis, some other lung issues, parenchymal problems, right? So you can go for number of diseases. In case control, what do? You are selecting 100 lung cancer patient going retrograde. A single disease you are focusing on. In cohort for 10 long years you are following them up, antrograde. Multiple outcomes. If 20 patient get this problem, you can study with this risk factor. This is also could be association. Okay. So number of disease could be studied in cohort, right? So all this, I hope you are clear with that. Okay, so the next segment is very exciting because it has got something which you know as maths, right? Maths students thought कि maths तो चली गई, but maths is back with a bang, surprise! Maths कहीं नहीं जा रही, maths हमारे दिलों में. Physics is the king of science and mathematics is the queen of science. Okay, without further ado, anyways, now we are going to study about the case control mathematics and after that cohort mathematics. Right? Don't worry, we are not going to go with formula. Even med students can easily solve this. Because we are going to go with something which is ground level approach. Like, let us take an example. Forget about the formula. At the end we are going to discuss. Right? We take an example of case control where we are studying after all those data analysis. We get the data in which there were 100 exposed. Let us take an example of 100 smokers. Out of them 80 got lung cancer, right? 20 have not got the disease. 20 have not got lung cancer, right? So out of 100 smokers, 80 have got lung cancer. So in this 80 your study, you are right. You might say, let's see, these were smokers, so that's the reason why they have got lung cancer. And this 20 are those who, in spite of smoking, they have not got the disease. So here you are right. Here you went wrong, right? Mark these words. I'm going to use this, right? Now in 100 non-exposed, 100 were non-smokers, right? Out of those 20 have got disease. You might be confused. They were non-smokers, still they have got the disease. I was wrong here. Just mark these words. Right? And out of those 100 non-smokers, 80 have not got a disease. You can proudly say that yes, see, they were non-smokers. That's why they haven't got disease. They haven't got the disease, right? So now in case control, mark these words. In case control, what do you do? To get the exact crux, we calculate the odds ratio. Odds ratio, as the name suggests, what are the odds? Right? So forget about those formulas, right? Imagine what is odds ratio is the ratio of I was right, all those conditions where you were right, divided by all those conditions where you are wrong. Okay? So in this condition, as you discussed, there were 100 exposed, right? And out of those 80 have got the disease. There are 100 smokers, out of those 80 have got the disease, right? So here you were right. Because they were smoker, they got lung cancer. They got lung cancer. You were right? And in this 100 non-smokers, 80 have not got the disease. You were right. And they were non-exposed. They have not got the disease. So here also you are right? Now, the denominator, what do you get? I was wrong. It is the ratio of I was right divided by I was wrong. In question, you don't need to figure out these tables, right? You don't have so much time to figure out these tables and ADBC and all those things. We'll figure it out anyway. We'll discuss that. But in question, you can quickly answer this. Out of 100 exposed, 80 got the disease. I was right. Out of 100 non-exposed, 80 have not got disease. You are right. In the denominator, out of 100 exposed, 20 have not got the disease. You went on wrong, right? And out of those 100 non-exposed, they were non-smokers. Still they have got the disease. Okay? So this is the ratio. 80 were exposed, 80 got disease, 80 were non-exposed, they didn't get the disease, 20 were exposed, still they did not get the disease, 20 were non-exposed, still they have got the disease. Okay, so this is the ratio. This is the odds ratio. What are the odds? Remember this line. You'll never confuse, because right now you might you easily understand with this table, but at the end in the question exam, there are 3 different conditions, right? Case control, cohort, randomized control trial. 3 different equations, 3 different tables. Don't try to confuse in this stuff. Imagine, get the crux, get the concept clear. Okay, so 80 into 80 divided by 20 into 20. Maths, 16, right? So 16 is the odds ratio. Right, let us still figure out the formula. Okay, what is odds ratio? Out of the cases, out of the exposed, how many got the cases? That is A, I was right. Out of the non-exposed, how many did not get the disease? Control, D, right? Now, what is? I was wrong. Where? Out of non-exposed, still they have got the disease. That is B, right? And out of exposed, still they have not got the disease, right? So this is C. So this is AD divided by BC. The same thing. AD into AD divided by 20 to 20, right? So it is 16. Odds ratio is 16. So if you want to go with this, you can go with this. Otherwise, this is amazing, right? Okay, so next we are going to discuss is the mathematics of cohort trials, right? Cohort trials. Cohort trials of mathematics is extremely complicated if you try to cram it, and is extremely simple. Is extremely simple if you go by the names. A wise man, Shakespeare, once said that what's there in the name? Arey bhaiya, solve these cohort examples. Everything is in the name. Everything is in the name. Go with the names. Go with the names, and you will easily solve any question of cohort mathematics, right? So let us take an example. We get the same example. 100 exposed, 80 got the disease, 20 did not get the disease. 100 non-exposed. There are 100 who are non-smokers, right? 20 got lung cancer, 80 did not get lung cancer. Now, simple, very simple, go by words. What is incidence in exposition? Somebody asks, what is incidence in exposed? Simple, out of those 100 exposed, how many got the disease? What is the incidence? Very simple. Number of exposed, the number of who got the disease divided by number of exposed. Very simple, incidence in exposed, 80 divided by 100, right? Very clear? Am I making sense? Right? Now, what is incidence? Incidence, how many got the disease? We are going for cohort, cohort is anterograde, right? Incidence in non-exposed. What is incidence? Incidence in non-exposed. Out of 100 non-exposed, how many got the disease? Is 20 by 100. Very simple. Very clear? Incidence in exposed. Remember, in cohort you go for incidence, relative risk, attributable risk, and proportional attributable risk. Remember this thing. In case control we go for odds ratio. Right? Okay, so in this is the same example. We understood the concept of incidence. Very simple. Now comes the problem. What is relative risk? Simple. Forget about this formula. Right? Forget about this formula. I am going to ask, what is relative risk? What do we do? Normal layman, what would the answer? If you want to find the relative risk, find how many smokers got the disease. You divide it by how many non-smokers got the disease. Very simple. What is how many smokers got the disease? Incidence in exposed. What is how many non-smokers got the disease? Incidence in non-exposed. A simple layman can also answer these questions, but we trap ourselves in formulae, right? So what is relative risk? Everything is in the name, Mr. Shakespeare. Okay? So relative risk is incidence in exposed. How many smokers got the disease? Incidence in exposed. How many divided by non-smokers got the disease? Incidence in non-exposed. 0.8 by 0.2, max 4, right? So relative risk of developing lung cancer is 4 times in smokers. Very simple, very logical. Incidence in exposed divided by incidence in non-exposed. Now comes attributable risk. What does attributable risk mean? Focus on the word attributable. How much would you attribute, right? How much would you attribute the risk factor in the causation of disease, right? The name says everything. How much would you attribute, right? If there is a director of a medical agency who comes up to you and say, okay, doctor, what did you do? How much if I carry out an intervention? If those 100 people I carry out an intervention, I spread awareness and they stop smoking, how much reduction of lung cancer would occur if I carry out this intervention? Tell me, would it be feasible enough? Should I spend my funding? Should I spend my energy in this? So how much would you attribute? Attributable risk is the difference, and you remember attributable is absolute. Is the value, is the difference. Okay, so how much difference would I get if I carry out this intervention? Okay, so see, incidence in smoker, a layman would even answer. Incidence in smokers was 0.8 and incidence in non-smokers was 0.2. So if you carry out an intervention, how much smoking attributes to the disease is the difference in these two, right? So it's the 0.8 minus 0.6. It is absolute. Remember, attributable risk is the difference, is absolute, right? The next I'm going to talk, we have to compare it with proportional attributable risk. So remember, attributable risk is absolute. So it is incidence in exposed minus incidence in non-exposed. Am I making sense? Very clear, right? So how much decrease would occur if I carry out an intervention? So how much do you attribute this risk factor to the causation of disease? 0.8 minus 0.2, 0.6. Finish. Now, what is proportional attributable risk, right? Proportional attributable risk. Okay, so that physician comes up to you and say that, okay, I understood that there is 0.6% decrease, 0.6%. But how much with respect to? You tell me how much with respect to? How much reduction with respect to the incidence in exposed, right? Out of 100 people, out of 100 exposed, 80 got, out of 100 smokers, 80 got lung cancer. Out of those proportion, tell me the proportion. I don't want absolute values, right? There may be different in samples and all the samples and all those things. First and foremost, give me the proportion. So how much decrease or how much risk factor could you attribute to the causation of disease with respect to, remember the word with respect to incidence in exposed. So simple is difference, incidence in exposed minus incidence in non-exposed divided by incidence in exposed. Don't forget about this. Whenever it is PAR, remember that is proportion. Whenever it is AR, is absolute. Tell the difference. Whenever it is proportion, tell the difference with respect to incidence in exposed. So it is 0.8 minus 0.2 divided by 0.8, 6 by 8 maths. Okay? Very clear, very logical. Incidence is how much? Incidence is very simple. Incidence, how many got the disease out of the total exposed. Relative is a layman would answer. Tell me the incidence is exposed divided by incidence is non-exposed. Attributable risk, the difference absolute value, and proportional is with respect to incidence is exposed. Okay? Let us talk about the formula if you want. Okay? So this is AR, out of the exposed, A got the disease, out of the total exposed, A plus B. A got the disease, B did not get the disease. Out of the non-exposed, C plus D. C, there was C who got the disease, C number of people, and D number of people did not get the disease. What is incidence in exposed? Is how many got the disease? A divided by A plus B. What is incidence in non-exposed? D, C divided by C plus D, right? That is incidence in non-exposed. What is relative risk? As we discussed, incidence in exposed divided by incidence in exposed divided by incidence in non-exposed. That is A divided by A plus B divided by C divided by C plus D. Okay? What is attributable risk? The difference, the absolute value. Incidence in exposed minus incidence in non-exposed. Right? Very clear. Proportional attributable risk. Incidence in exposed divided by incidence in non-exposed divided by incidence in exposed minus incidence in non-exposed divided by incidence in exposed. Very simple. Very simple. Just keep your concepts clear. You can easily answer. You don't need to think about making all those tables and trying to recollect all those formula and all. Just imagine. Just go with the words. Everything is there in the name, right? And don't confuse. We are going to discuss after this. We are going to discuss about RCT. Okay? So we'll have to in that I'll compare. I'll definitely clear the confusion. But remember all those words. In case control, we go for odds ratio, right? In cohort, we go for incidence, we go for relative risk, we go for attributable risk, and you go for proportional. So guys and girls, you might have heard nowadays so many studies being going on, especially in this COVID times, right? Right? So there are so many studies being going on, like you might have heard that Remdesivir was approved, then it was rejected for emergency drug use, it was approved for reducing mortality in plus 70 patients, it was approved in reducing mortality in ICU stay patients, tocilizumab and ivermectin, this has been approved, hydroxychloroquine, all those things. You might be confused what these studies are, right? You might be confused. Till now we discussed case control and cohort, they don't fall in them. You might be confused what these actually are. The answer to that question, guys and girls, the answer to that question lies in our last part of the discussion. That is the randomized control trial. This is known as the classical interventional study. Till now what we studied was case control and cohort. They were analytical studies, right? This is interventional study, one of the most interesting part of the discussion, right? What is randomized control trial? This chart I have taken from a standard textbook and it is very interesting. But before focusing on this chart, forget about this chart. Today, we are right away, we are clinicians, right? We are going to go with a ground level approach. We are going to do a randomized control trial right away, right? What the status quo right now is about the black fungus, right? Mucormycosis. So many cases in India, right? So let us do a randomized control trial. Amphotericin B is so effective, but I don't trust. I want to go for a randomized control trial. Let us do, right? So we are going to do today itself a randomized control trial of the effectivity of amphotericin B in the treatment of mucormycosis. So let us begin, guys and girls. Let us go for a ground level approach, right? So first and foremost thing is, it is very common in Gujarat, right? It is very common in Gujarat right away, right? So what will you do? We select the population of Gujarat. Let's suppose take an arbitrary value, right? There are 1,000 cases. There are 1,000 cases of mucormycosis in Gujarat. So the first criteria we inserted over here. In our study, which then you will say, after getting the assessment, after getting the result, we will say that I selected this population, right? So we are selecting 1,000 population or 1,000 mucormycosis patients, in Gujarat, right? In Gujarat, out of those 1,000 patients, right? I want to refine it more. What will I do? Okay, I'll say I want to study the effectivity of amphotericin in greater than 70 years patient only. Okay, so I want to refine my trial and analysis. Okay, so out of those 1,000, I add a criteria that with more than 70 years patient, right? So it turns out to be, let's suppose, 500 patients now. So you are getting 500 patients of mucormycosis in Gujarat who are having greater than 70 years of age. So this is the study population, right? This is the experimental population, which you will say, and they should be selected randomly. Mark my words, they should stand the representative of the population, right? So these 70 years, greater than 70 years, 500 patient you select should represent the greater than 70 years patient of the whole Gujarat, of the greater than 70 years patient of the whole of Gujarat. It should be representative, right? So we have 500 patients who have greater than 70 years of Gujarat, right? The next step is exclusion. Now I still want to refine my study, right? I just want to study ICU patients. Effectivity of amphotericin in ICU patients. It turns out to be, let's suppose it turns out to be 250 patients, right? Now, out of those 250 patients, I ask for consent. Well, I want to get the consent. I want to study the effectivity of amphotericin in those 250. Out of those 250, let's suppose 150 deny. They don't give the consent. So we get the 100 patients of mucormycosis. 100 patients of mucormycosis. These 100 patients are the patients who are entering in a trial. Till this time, it was the refining process which are going on. These 100 patients would be entering in our trial. What are these 100 patients? And they are from Gujarat. They are greater than 70 years. They are having ICU stay. They had ICU stay for long. Okay, that's the criteria which we have put together, right? And they are those who have given us the consent, right? So these are 100 patients. These are 100 patients who will be entering in our trial and who will be randomized. This is most important. We are going to discuss it, right? This is the randomization is the most important part of RCT, right? Out of those 100 patients, 100 patients in ICU stay to 50 patients, let's suppose to 50 patients, take arbitrary value. I give amphotericin, right? And to 50 patients, I am not giving amphotericin, right? Then I'll be going for manipulation and follow-up. That is, I'll be giving amphotericin, and I'll be following them up. And at the end, I'll be going for assessment. I'll be going for radiological assessment. I'll be going for symptomatology, all those things, and how much effective amphotericin was in reducing these things, right? So let us now correlate the words, correlate the terms from standard textbook with the example we took. The population, what is the concept? The population is the population of Gujarat we selected. Now the sample should stand the representative of population, the representative of the whole population. So that is 500 patients greater than 70 years. That is the sample we chose, right? Then there are exclusion. So who are not eligible, who are not in ICU stay are not eligible. 250 patients are not in our trial. Out of those, 150 people didn't give consent. So we have 100 patients. Then we go for randomization. 50 are given amphotericin, 50 are not given amphotericin, right? We follow up and we assess, right? This is the concept of randomized control trial. That is interventional study. The classical word over here is we are putting an intervention, we are giving a drug, right? Case control and cohort. What was that? It was exposure risk factor versus the disease occurrence, right? Both are totally different. That was analytical study. This is interventional study. Now the exact difference between analytical and interventional study is the concept of randomization, right? Is the concept of randomization. As I said, it is the most important, and it is done once the patient enters in the study, right? It is done once the patient enters in the study. It is definitely done not before. After the 100 patient enters, then we are going to randomize. randomized, right? Each has the equal opportunity, right? So the 50 patients will be experimental, 50 patients will be control, right? In analytical study, the difference between analytical and interventional study is randomization. The classic difference: in analytical study, we don't do randomization. Obviously, in case control, there are 100 lung cancer patients, 100 who are control. There is no randomization in that. All those are patients having diseases. These are patients in which we are studying the effect, of the intervention, that is drug in our case, right? So that is the most important part. Randomization, right? Randomization. And bias. The bias is an issue. Bias is a very important issue over here in randomized. Observer's bias, right? In observer in hand, let's suppose the observer in hand knows that these are the 50 patients. There are two separate ICUs, let's suppose, and he knows that these are 50 patients who have been given amphotericin, right? So while looking for the clinical features, the observer in hand knows that definitely I think that they would have improved. So they get the bias. Subject variation. What does subject variation mean? The person in hand, these 50 patients who are being given drug, let's suppose in hand knows that they are being given drug. Then definitely there is a bias. Then the person feels that yes, I am being given a drug. He would say, yeah, my headache improved. Yeah, definitely. And what is investigator evaluation? After you get the data, the investigator knows that this data of 50 people are those data which have been given amphotericin and these have not been given. Then definitely there would be a bias. So these are the three biases which we need to eliminate in randomized control trial. And what is blinding? We all know what is blinding. There are three types of blind: single, double, triple. What is single? The subject who is being given the manipulation or intervention doesn't know that he is being blinded. That is single blind, right? What is double? The doctor who is examining the clinical features, the doctor who is going for radiological investigations, the doctor who is testing for the prognosis, he doesn't know whether he has been given drug or not. At the same time, the subject doesn't know, right? And what is triple? All three doesn't know. Subject doesn't know, doctor doesn't know, and the analyzer who is going to analyze the data, he also doesn't know whether he has been given amphotericin or not, right? So this is the concept. This is the the crux concept of randomized control trial. Okay, so some few things here and there about RCT, right? There are two types of RCT: concurrent parallel study designs and crossover study designs. What is concurrent parallel, right? In the example we took, right, the 50 patients were given the drug, that is amphotericin, right, and 50 patients were not given, right? So simply you continue this study, 50 patients were given, 50 patients were not given. At the end you observe and you compare the outcome, you go for analysis, right? Now what is crossover study design? What is crossover? As the name suggests, everything is in the name. 50 patients were given the treatment, 50 patients were not given the treatment. After some period of time, you observe, you analyze. After that, what do you do? You cross over, you switch over. Those 50 patients who were the control in your study in the initial phase, right? What will you do? You'll start giving them treatment in the next phase, right? And those who are given treatment, you'll stop giving them treatment, right? And after that, you observe. So this would be a better option, but it is not possible in some of the diseases where there is cure occurring. Let's suppose there is a bacterial infection, right? You give the treatment, you give the antibiotic, right? Here the patient has already cured, so you can't go for this. So crossover studies couldn't be done in this condition, in some conditions where the disease is already cured over here. You can't go on this step. But this is a better one, you get a confirmed result of this, the outcome is there or not, right? Okay. Now, and where can RCT be used, right? As we discussed about drug, the effectivity of drug, like in clinical trials, right? Effectivity of vaccines in preventive trials. You can go for risk factor assessment. You can go for cessation experiment, right? Let's suppose smoking cessation would be helpful or not. That is an intervention, right? And you can confirm the etiology, right? One of the examples which was given, right? That the incidence of retrolental fibroplasia was more in those infants which have been given oxygen therapy. That is true or not? So all those conditions, basically as I discussed, all those things we hear about, drug effectivity and those trials are all the part of randomized control trial, which we know as interventional trial, right? Okay, so guys and girls, we have reached the last part of our discussion, and that is the mathematics of randomized control trials, right? We are going to take the example. We are going to take the example so that you don't get confused with formulae, right? in the same example we took in the discussion of RCT, there are 50 patients. Let's suppose there are 50 patients who are given amphotericin. Out of them, let's suppose 40 people get cured. So 40 people are not having disease. 40 people are not having disease. And out of those 50, 10 people did not get cured. They are the 10 people who are having the disease. Mark my words. This is what we are going to use in the calculation of incidence. Mark my words. We are going to take this matter at the end, right? The 50 patients in which we did not give amphotericin, right? Those were the control, right? Out of those, 10 people got cured. They are not having disease, and 40 people did not get cured. They are having disease. So RR is the same. First and foremost, we are going to discuss about RR. RR is the same. We want to know the effectivity of the drug. So out of those who were given the intervention, how many were cured? Is the ratio of that with the people who are not given the intervention, and out of those how many were cured? So it is 40 divided by 40 plus 10 divided by 10 divided by 10 plus 10 plus 40 turns out to be 4. Okay, so it is 4 times effective. That's what you can say, right? In curing this is very common. This is very easy to understand, right? Now the problem lies in these two terms, right? In these two terms, the basic problem is we always confuse it with cohort. And you don't understand the difference. It is very confusing in exam. So let us clear the confusion right away. Right away we are going to clear the confusion. Why is the difference in formula? What actually the basic concept? What actually the crux of this is? Right? So absolute risk reduction. First of all, let us discuss RCT. Absolute risk reduction. What happens in RCT? What is incidence? What is incidence? Is this area, as I said, I'm going to discuss it at the end. This area is the incidence, is disease occurring at the end of intervention, right? That is incidence. What is incidence? It is disease. And what is intervention over here? That is exposure. We are using the same term over here. Exposure, non-exposure, exposure, non-exposure, right? What is exposure? Exposure in randomized control trial. It is the intervention. It is the drug which is protective, right? It is protective. So exposure would lead to decrease in incidence. Am I making sense? Exposure. This line is short. We'll clear the confusion between RCT and cohort mathematics, right? So exposure, that is drug, will decrease the incidence of disease, right? As you see in this example, right? So absolute risk reduction as far as RCT is concerned is incidence in non-exposed, is the disease occurring in those subjects in which the drug has not been given, minus incidence in exposed, right? So you can calculate it is 40 by 50, incidence in non-exposed 40 by 50 minus 10 by 50. Incidence is this. It is not this. Understand? Am I making sense? Incidence is disease occurring. So the biggest mistake we do is we keep this over here. No, it is not. It is the incidence, that is the disease occurring, which would be more in the group which is not given the intervention, which is non-exposed, right? So incidence in non-exposed minus incidence in exposed, 40 by 50 minus 10 by 50, 3 by 5. Making sense? Maths. Okay. Now what is relative risk reduction? As we discussed in cohort, right? It is out of the proportion. Tell me the proportion, how much it decreased, right? Incidence. So that's why it is incidence in non-exposed minus incidence in exposed divided by incidence in non-exposed. Am I making sense? It would be more in people who are not exposed. Incidence would be more because the disease, we are considering the disease remaining at the end of study, right? So it is incidence in non-exposed minus incidence in exposed divided by incidence in non-exposed. So this was 3 by 5 as you already calculated. And incidence in non-exposed is 40 by 50. Answer turns out to be 3 by 4. Maths. Now let us compare in hand. Let us clear this confusion for all, right? So what happens in cohort? RR we already understood, right? What is AR? What is attributable risk? We already discussed how much do you attribute. Here incidence in exposed minus non-exposed, right? Because the disease was more, disease would be more in people who have been exposed to their risk factor. Am I making sense? In cohort, I have written this. In cohort, exposure is causing disease, right? In RCT, exposure is curing disease. This is the crux. These two lines, you will remember these two lines. You will never make a mistake, right? So exposure is causing disease in cohort. That's the reason incidence would be more. In short, if you want to remember, right, in this area, you will subtract from the value which is more. You can logically think, right? You will subtract from the value which is more. In cohort, incidence would be more in exposed, right? Incidence would be more in exposed because exposure is causing disease, right? So you'll keep it over here and you'll also keep it on denominator, right? Over here in RCT, incidence would be more in non-exposed because that is the group which is not getting exposed to the disease, right? So over here, the bigger value would be this. So incidence in non-exposed minus incidence in exposed, right? In cohort, attributable risk is incidence in exposed minus incidence in non-exposed. The bigger value minus the smaller value. Now, proportional attributable risk, we already discussed incidence in exposed minus non-exposed divided by exposed. Here it is non-exposed minus exposed divided by non-exposed. Right? So bigger value over here, bigger value over here, bigger value over here, and bigger value over here. Am I making sense? Let us discuss the formula for a short. Right? This is the table which you might be given in the literature. Right? Cure out of those who are given treatment, A were the number of people who were cured, B were the people who did not cure. In this group of people who were not given treatment, C were the number of people who were cured, D were the people who did not cure. What is RR? A divided by A plus B, C divided by C divided by C plus D. Right? ARR is incidence in non-exposed minus incidence in exposed. That is what we discussed. And what is RRR? It is incidence in non-exposed minus incidence in exposed divided by incidence in non-exposed. So guys and girls, that was all about the concept and the discussion of trials in community medicine. I hope all of you all enjoyed, right? This is Dr. Mihir Tejura signing off. If you have any doubt, you have any suggestions, you have any query, you might contact me on the platforms. You can see on the screen. Thank you so much. And don't forget to go with the ground level approach. Remember, we are clinicians, right? Go with the ground level approach, right? Thank you so much.